Anxiety by definition is symptomatic. It's like irritability. The difference between being angry or justifiably annoyed or frustrated and being irritable. When you're irritable, you're getting angry at things that shouldn't make you angry. And it has to do with body chemistry. It has to do with dopamine and epinephrine and estrogen and serotonin and the balance between all of those chemicals and more. In a similar vein, anxiety by definition is always irrational and excessive. It is always a symptom. So if you're worried about a presentation, if you're worried about your health, if you're worried about something that is reasonable to worry about, and it's not overwhelming, and you're not obsessing, and you're not catastrophizing, and it's not disabling, it's not causing dysfunction occupationally or academically or socially, then we might not label it as a condition, as an illness, but we can say that that worry is unnecessary, it's not helping matters. In that sense, it's a symptom, it's irrational. Thinking about it, worrying about it isn't going to make it any less likely to transpire. It's not going to, certainly preparing for things and taking precautions and being careful. I mean, there's evolutionary significance to feeling anxiety. But people with anxiety syndromes, like generalized anxiety disorder, panic disorder, and specific phobias, their anxiety is clinically relevant. It is not only irrational because it's a little excessive, but it's extremely excessive. It is well beyond what a person should be experiencing. It plagues the person. There are usually physical manifestations, whether it's insomnia or headaches or high blood pressure or palpitations or actual panic attacks. And it is disruptive to their lives and potentially even disabling. There's impairment in social, academic, and or occupational functioning. And it behaves differently, that anxiety. First of all, it requires medication. Deep breathing and going to therapy and using those techniques are all well and good, and they're encouraged, but you'll be forever taking timeouts and telling yourself to take a deep breath and not to panic and not to overthink it and not to catastrophize, or you'll be forever telling yourself not to dwell, but the thoughts will keep creeping back in. And so you can do things to attenuate, you can be healthier and cut certain things out of your diet and avoid caffeine and other stimulants. You can do the holistic, homeopathic approach. But if you have obsessive compulsive disorder, and a lot of people live with it, but if you have that, or if you have social anxiety disorder, it's not going to go away. The symptoms themselves, they can be managed and they can be mitigated, but they're going to be experienced unless you take medication, because it's like being diabetic and not having enough insulin. You can be very strict with your diet, but if you're a type 1, then you need insulin and you're always going to have high blood sugar, and really you should take medicine. Now, for individuals with these syndromes, it depends on the severity. People can live with mild OCD, and people can live with mild social anxiety. Sometimes people will self-medicate with over-the-counter preparations. A lot of people with social anxiety will use alcohol to relax them before social gatherings. But the severe forms are like type 1 diabetes versus type 2. Where in type 2, you could lose weight, you could exercise, you could avoid starchy and sugary foods, and you can bring your hemoglobin A1C level down and have better control of your diabetes, or maybe not need to take medicine, and certainly not have to take insulin. You can definitely avoid that and maybe just take pills, or even no treatment at all if you lose enough weight and monitor your diet, depending on the severity. But if you're a type 1, brittle, juvenile onset diabetic, then you have to have insulin. Your body's not making it, and you could avoid the wrong foods all you want, and you can be very fit, and your body mass index could be perfect, but you're going to need medicine. So people with severe OCD and severe social anxiety disorder, people with panic disorder, which is essentially severe generalized anxiety disorder, as far as I'm concerned. In practice, in actuality, not according to the DSM-5, I consider it to be just an extreme form of endogenous anxiety caused by inadequate serotonergic neurotransmission. The patients that have severe disease, they need to be on medication, and they need to be on medication forever. The medication, they will respond robustly. That's the good news, is that they respond much more dramatically in their lives, are much more improved than people who are anxious because of situational factors, people with adjustment disorders with anxiety, for example, people who just got fired or divorced. There's a lot of anxiety, and there are even physical symptoms of anxiety. They are ill, where you would diagnose something like an adjustment disorder or another anxiety spectrum illness that's clearly exogenous. It's clearly triggered by external events, and so medications can help in those cases too, but they're not as dramatic. They're not as life-changing as they are for people that have that deficiency to begin with. And so these patients get a whole lot better. Now, anxiety is treated with antidepressants. They're classified as antidepressants, but really they're also anxiolytic agents. What we want is increased serotonin, but these conditions require higher doses, the highest doses, in fact. OCD requires very high doses, and OCD and social anxiety require very high doses and are stubborn. They don't necessarily go away 100%, but they're greatly attenuated on medication. And they also take a long time. They take a lot longer time. And if there's comorbid depression, which is pretty common, the depression almost always gets better sooner and at lower doses than the anxiety. And so there's a progression. Irritability gets better overnight, depression gets better over a period of days to weeks, and the anxiety, really, if we're talking about full remission, weeks to months. And the other thing that's important to know about treating patients with endogenous anxiety is that at the initiation of treatment, or when the medication is initially titrated, when the dose is increased for the first time, patients that have endogenous anxiety that are very sensitive to fluctuations in their serotonin levels can have a seemingly paradoxical worsening of their symptoms. Their anxiety is worse for a few days, for just a little bit, until they get to steady state, until their blood levels are not varying because they've just started the medication or increased the dosage, and they're not at that steady level, that steady blood level. Their blood levels waxing and waning with dosing, and it takes 5 half-lives. So whatever the half-life, it takes 5 of those to get to a state where if you're taking the medication, then your blood levels don't fluctuate and you don't have those ups and downs that in patients with endogenous anxiety causes them to feel worse. And so I had a case recently where a patient had panic disorder and the panic attack stopped, as they always do, but his generalized anxiety, which he hadn't had before, or at least hadn't noticed, was worse. And patients with generalized anxiety don't necessarily start having panic attacks by any means, but they do feel often a heightened sense of anxiety. And so we bridge that gap using benzodiazepines, usually tranquilizers like Xanax or Valium, to tide people over. It's very difficult treating those patients because they're afraid of the treatment as well. And that's very common to have fear that the medication will actually make them worse in a permanent way or cause bodily harm if they take it for the rest of their lives. And so they can be very reluctant to start therapy and to increase the dosage. The irrational fears often are also related to the treatment. So the symptom threatens to sabotage its own cure. Dosage adjustments have to be very gradual in these patients because they can sabotage treatment. I'll often start at even lower than standard starting doses, half the standard starting dose, so as not to exacerbate the anxiety, and also so as not to spook the patient into never wanting to go near the medication again, particularly those patients who are anxious about taking medication. I often, when I do titrate it, I wait longer, and I also, rather than having them take it all at one time, will divide the dosage, even though the standard thing would be, for example, starting Celexa citalopram at 20 milligrams, and then increasing to 40. I would start with 10, and then I would increase to 20 much later than normal, and I would divide the dose and give it 10 milligrams twice a day, and make sure the patient's taking food to slow down absorption. So I would be a lot more cautious about proceeding. These patients also require a great deal of reassurance in order to not abandon treatment and to have an adequate therapeutic trial, which means taking a high enough dosage for a long enough period of time. And for these conditions, they require the highest doses and the longest periods of time. It's important that sometimes you have to do some hand-holding, and so it's important to encourage patients to get in touch with the practitioner if they are tempted to stop taking it, either because their anxiety seems to be a little worse or because they're having side effects which seem intolerable but which are transient and which will get better with time, or which we can use an antidote for. So there's a rough patch at the beginning, but if we can get patients with these conditions, particularly patients who are being treated for the first time, and particularly patients whose personal philosophies are naturalistic and holistic, and who eschew Western medicine's pharmacological interventions, just generally, particularly those patients need to be encouraged and monitored and brought back sooner to clinic, and there's still a tendency for them to abort the medication or not increase the dosage as planned or to deviate from the plan. And sometimes they are forthcoming with their reservations and sometimes they're not. They also often have to be convinced to stay on the medication long term. Many of these patients are loath to do that.